Oh, welcome again to Miami Community Health. I am Dr. Anthony Gonzalez, your host. March is Colorectal Awareness Month. Colorectal cancer is the second leading cause of cancer death in our country. 150,000 colorectal cancers in 2023. It's important to have awareness for colorectal cancer. Everybody's heard, get your colonoscopy. Make sure you don't have polyps. So we're going to learn a little bit about that. We're going to bring awareness about colorectal cancer because it's Colorectal Cancer Awareness Month in March. And of course, to talk about colorectal cancer, we have to bring a colorectal surgeon. So I brought Dr. Victor Maciel, who is our colorectal surgeon at Baptist, who helps us deal with all that colon and rectal cancers that we deal with at Baptist Health. Welcome, Victor.
Thank you, Tony. Thank you for having me. It's a pleasure. I am very happy to be here and share the awareness about colorectal cancer. As you said, it is a very, very important thing for our audience to be aware of because it saves lives. You know, be aware of all the things that can make your colon healthy and be a better, longer life.
Yeah, no doubt. And saving lives is something that's very important because early diagnosis is very important. That's why the colonoscopy is so important in that. Is that right?
Absolutely, absolutely. One of the things that drew me into the colorectal field is that colorectal cancer has become a curable disease. The sooner you diagnose it and the faster you treat it, the better your chances of curing. So I wanted to be that kind of doctor that brings good news to patients. But the most important part that needs to be happening in that equation is early diagnosis, screening, and patients being aware they need to do the screening colonoscopies.
All right, so before we get into colorectal cancer, let's talk about the colon. Explain to people the colon and the rectum. You know, what is that? We know it's the intestines, but so people understand.
Right, so the colon is formerly known as the large intestine. We have small intestine and large intestine is the last 5 meters of your intestine and starts with the right colon, goes into the transverse, descending, and the final 15 centimeters of the tract is the rectum. So colon and rectum is the last part of your gastrointestinal system. Its main function is to absorb water and solidify the stool, and it serves as the rectum serves as a reservoir for the stool before having bowel movements.
All right. And so we're talking about colorectal cancer. What type of risk factors predispose some patients to really have colorectal cancer? Are there certain habits? Are there genders more likely? Age?
Well, the most important risk factor is genetics, but there's things that we can do to decrease our risk factors, our risk of colorectal cancer. For example, obesity, we know that has been very strongly linked to colorectal cancer. Drinking, smoking, and most recently, high red meat diets, low in fiber, have been proposed as also risk factors for colon cancer. Sedentarism and lack of physical activity, constipation, all those things. Unfortunately, we can adjust those risk factors with a healthy living, and for the factors that we cannot change, like the genetic part of it, fortunately we have colonoscopy to screen and detect the patients that will produce more polyps before they become cancerous. So we do have a lot of ways to impact colon cancer, detect it and treat it early.
Now, you mentioned some of the things that we can change, you know, obviously smoking and drinking and obesity. What about gender and age? How does that impact colorectal cancer?
So the colon cancer affects older patients, but now what we've seen is younger patients being diagnosed with colon cancer at earlier ages. The cutoff was 50 years. So patients younger than 50 years have been diagnosed with cancer more frequently. And therefore, the recommendations for screening have been changed. Now we recommend colon cancer screening at 45 years old. The genders have been equalizing, and we recommend the colonoscopy for both men and women and people of all races and genders at the same time.
So obviously, we were talking before you even started that, you're doing colonoscopies on patients and you diagnose, conditions on patients. Now, screening and doing a colonoscopy on somebody who has no symptoms at all at the age of 45 is one way to detect colon cancer. Now, what happens if the patient had not had their colonoscopy? Are there symptoms that really would be worrisome to you as the physician that maybe somebody has colon cancer?
Right. Tony, before we move into that question, I would like to clarify something about the last question. These recommendations of a screening at 45 years old is for average risk patients. Patients that have higher risk of colon cancer need to be screened sooner. So if you have a family member that was diagnosed with colon cancer at earlier ages, you should be screened sooner. And the decision at when needs to be discussed with your physician, your primary care doctor, your colorectal surgeon, your gastroenterologist. All right, now moving on to the symptoms. Symptoms of colon cancer that can alert a patient that something is wrong is changes on bowel habits, changes on the frequency, the quality, the caliber of the stool, blood mix in the stool, dark stools, anemia that is not explained, weight loss, all of those things. But now, since the colon is such a big organ, long organ, the symptoms associated with left colon cancer and rectal cancer are different than the symptoms associated with the right colon cancers. On the left, it tends to be more kind of obstructive symptoms, difficulty having bowel movements, thinner caliber of the stool, stool mixed with blood. And when you have a colon tumor on the right, those symptoms are more subtle because the stool in the right side of the colon is more liquid, and therefore a tumor won't give symptoms until it is very large. And again, for this reason, we recommend screening colonoscopies to detect the tumors that could be asymptomatic but large enough to give problems. So the majority of the malignant masses in the colon are asymptomatic. Very important.
Now, we keep talking about colonoscopy. Let's clarify. Polyps lead to colon cancer.
Yes, sir.
Right. So why don't we go through that? Because people have to understand the importance of your gastroenterologist goes in there or your colorectal surgeon goes in there and removes these polyps. I mean, he's basically saved your life, right? Because polyps eventually lead to cancer. Talk to us a little bit about that, because that's important for people to understand that.
Absolutely. Absolutely. I think that is the most important thing for our audience to understand, that colon cancer is not something that just appears. Is a disease that is progressive, and damage to the inner lining of the colon, either by toxins in the foods that we eat or drink or smoke, or accumulative damage in the genetic material of those cells, produce changes that create growths. Now, the growths are millimetric, and over the passage of years, they can turn into larger masses. And the more they grow, the higher the chance of harboring a cancer. So it is like a weed. When you see something growing in your garden that you don't want them, you have to root it out, right? So us endoscopies, that's what we do. We go in the colon, find those little polyps, and cut them before they become a problem. And it's been proven that patients that follow the scheduled colonoscopies tend to live longer than patients that do not. Very important.
And how long does it take from a polyp to get all the way to a cancer?
It's a matter of years, Tony. It's 7 to 10 years.
Wow.
Yes. So
that's just a long period of time.
Exactly. And that's why we recommend colonoscopies every 10 years for average risk patients. So if you go in, do your colonoscopy, spend the 30 minutes in the endoscopy suite, you get 10 years of peace of mind. So very important.
All right. Are there any other screening tests for colon cancer, for colon polyps? You know, we do see them. I see them on the advertising, on the TV. Patient said, well, I had a CAT scan. I don't have a colon cancer because I have a CAT scan. They check my colon, right? You and I know that that's not a test. So let's talk about, are there other good and bad screening options?
Right. There are many. A CAT scan per se is not a very good test for finding tiny millimetric polyps. It's just not precise enough, not fine enough to find those little polyps. There is stool-based screening tests, but they are also not perfect. And for example, the Cologuard and the FIT tests, it involves still, sending a sample of your stool, and then if it comes back positive,
You still need a
colonoscopy. So my recommendation is to proceed with colonoscopies. And the reason for it is because it is the safest, okay? It detects the polyps and treats the polyps at the same time. So the only gold standard, it is colonoscopy for this purpose.
Wow. So what I've heard over and over so far about colorectal cancer awareness is colonoscopy, get your colonoscopy.
Absolutely.
And obviously, age 45, unless family history. So let's talk about family history. What are those family histories that are important that those viewers will, can wake up in their mind and say, I've had a mother or a grandmother, or is it an aunt? Is it, my great grandmother? What is the family history that's important in deciding on when to have a colonoscopy?
Right. So first degree family member with a cancer diagnosed at an early age, the relative needs to be screened 10 years before that patient was diagnosed, that family member was diagnosed. So for example, let's say your father had a colon cancer at 50, you better screen yourself at 40. And history of polyposis syndromes, let's say that your sister had a colonoscopy and they found 100 polyps, you need to get screened as well.
Not that your sister was found to have a polyp or a few polyps.
No, it needs to be a large number of polyps, more than 10.
That's what we want to clarify that.
Yes.
All right. So unfortunately, colorectal cancer exists. 150,000 of them last year in the U.S. You diagnose somebody with a colon cancer. What is the treatment?
The treatment changes in, it depends on many factors, all right? First, we have to divide the colon away from the rectum. The rectal cancers are treated very differently than the colon cancers. Let's focus on colon. The colon cancer the treatment starts with surgery. And depending on the staging, the medical oncologist may decide to give chemotherapy or not. But many times, surgery is curative for these patients, all right? For rectal cancer, the treatment may include neoadjuvant treatment, meaning chemotherapy and radiation before proceeding with surgery. And for rectal cancers, the treatment has become so good that sometimes we don't even need surgery.
Wow. All right. And people always hear about the colon and they always think, well, you're going to do surgery on my colon and I'm going to have to wear a bag for the rest of my life, right?
Yes.
So let's talk a little bit about the surgery, the advancement. I know robotics, you're very much in robotics as well.
Yes.
So tell people, give people a picture of like what these surgeries are like and what is the recovery like and that they don't have to wear a bag,
No. So colon cancer is a major operation that requires general anesthesia and requires removing a large part of your body. But we have become so good at this type of procedures, we have developed minimal invasive techniques that help the patient recover faster with less pain and less risk of having a colostomy bag. Basically, a colostomy bag is a temporary solution that the surgeon sometimes needs to use to allow the patient to recover from the surgery or from the initial insult. And is not a thing that anybody wants to have, and it's not a thing that the surgeon wants to give a patient, but sometimes it does save lives. Now, with the minimal invasive techniques that we have, and with proper patient selection and patient optimization, that risk is minimum. It should be less than 10%, 5% in an elective, well-selected case. I do laparoscopic surgery and robotic surgery, And with the robot, I'm able to do more complex surgery with a minimal invasive technique that also decreases the chances of having a colostomy bag. But I also want to have the audience know that even if we have to create an ostomy, rarely they are permanent. Now we're becoming more aggressive at reversing the ostomies. So it's a large part of my practice, reversing ostomies as well.
And, I think it's important to mention how colorectal surgery has been one of the leaders in what we call enhanced recovery after surgery, right?
I'm glad that you bring it up.
Yeah, that's a great area. For our viewers, enhanced recovery after surgery, ERAS, E-R-A-S, has been a process that was started in England, and it was to help orthopedic surgery and colorectal surgery, and patients are treated very differently before and after surgery. And like patients are allowed to drink Gatorade 2 hours before surgery. Patients are not starved. Patients are fed immediately after surgery. You're not spending 7 days in the hospital. So talk a little bit about the enhanced recovery protocols around colorectal surgery.
Yes, sir. So when I started my residency years ago, the ERAS protocols started in my program, and I had the opportunity to see how a patient with an open colon resection recovery compared to the newer generations with the newer techniques. And I couldn't believe that a patient with a major colon resection was leaving the hospital in a day and a half, eating, drinking, and pain-free, with only taking Tylenol and ibuprofen. That was shocking for me. And I'm glad that we have very good protocols in our hospital that help our patients recover fast. It is really incredible to see a major operation being done with a single incision or 3 small incisions the size of my pinky, and walking, having bowel function at a day and a half, and only taking Tylenol. It is amazing.
Wow. All right. So we've talked about the surgery for colon cancer. We talked about radiation, chemotherapy may be needed for rectal cancer. Are there advancements in the future? What's going to happen in the future with treatment for these? Have you noticed any advancements in colorectal cancer treatment?
Definitely. For my specialty, the biggest advance that I've seen is robotic surgery. In the medical treatment of colon and rectal cancer, there have been many advances in genetics and targeted therapy and early diagnosis and follow-up with liquid biopsies, they call it. It's just a way to monitor the recurrence of a colon cancer so we can treat it and look for recurrences before they are even symptomatic. In addition to that, the medical oncologists can treat the particular type of cancer patients have with tailored chemotherapy and immunotherapy to make the cancer go away. And there have been several reports of cancers being cured that would otherwise be determined to be incurable. And fortunately, we partner in our institution with the best medical oncologists, radiation oncologists, radiologists, radiation therapists, and we sit down together weekly on tumor boards, and we discuss the particular case of a particular patient with a particular tumor and offer that patient a tailored solution. The use or the participation on tumor board conferences have demonstrated better survival and better outcomes for the patients.
So that's important for our audience to understand that their case is being studied among all the specialists together. And I think that's one of the biggest things that patients always complain about, that doctors don't talk to each other. Oh, you didn't talk to my other doctor. You didn't talk to this doctor. But you guys, in this type of discipline, you guys are having this multidisciplinary approach.
Definitely. And also, I mean, when you receive a diagnosis of colon or rectal cancer, it is overwhelming, right? And we do, besides having the tumor board discussions, we do have nurses and other staff that helps the patient navigate through what's the next step, right? So they don't forget about, oh, I have an appointment with the medical oncologist this day and the radiation oncologist this day, the surgeon this day, because even after the cancer is treated, there is an intense follow-up that needs to be continued for the patient. So we do have a very efficient nurse navigator system that makes sure that the patient gets to the treatment that they need, and we help them solve social issues, transportation issues, etc. So we're a very good team, and we have demonstrated to have very good outcomes with this approach, multidisciplinary approach.
So it looks like there's phenomenal resources within Baptist Health for colon and rectal cancer.
Yeah.
Are there other resources in our community or nationwide that you would tell, hey, if you've had a family member with colon cancer, these are other resources that you can use to help as well?
Resources like information, education.
Yeah, is there the American Cancer Society?
Right.
Are there other societies or
Yeah.
other organizations that really help as well?
I am a member of the American Society of Colorectal Surgeons, and their webpage is a very, very important resource. We have resources oriented to educating families, educating primary care doctors. So I would recommend to go to a formal organization and to listen to awareness publications like the ones that we're doing, and do not let them be confused by other not so trusty sources.
So reputable sources.
Exactly.
Right. Okay. So obviously we want everybody to be cured. We want everybody to have their polyps removed, and we don't want anybody to have colorectal cancer. But the reality is that we are going to see colorectal cancer. And you said it's a curable condition.
Mm-hmm.
So talk to us about the cure rates and the survival rates, depending on the stage, right? Because the stage, it makes a difference whether you present with a small cancer, whether you have lymph nodes, whether you have metastasis. Talk to us about metastasis to the liver, to the lungs. So talk to us a little bit about that.
Yes, Tony. So as a tumor, a polyp grows, it tends to grow into the inside of the bowel and also into the wall of the bowel. Okay, so the staging depends on the depth of invasion into the bowel wall. Okay, so if you have a tiny polyp with just a few cells that are looking malignant, it's considered an in-situ cancer. It is malignant, but hasn't grown enough to spread. When you discover a polyp with those characteristics, the cure rate only with endoscopy is 100%, very close to 100%, right? And as the tumor progresses deeper and deeper into the bowel, gains the ability to travel through the lymph nodes and travel through the vessels and create deposits in distant places. Those are called metastases, which is colon cancer living in the liver, living in the lungs, okay? For stage 1, the cure rate is about 90%, and it starts decreasing depending on the depth of invasion. But also, the multidisciplinary approach to colon and rectal cancer has allowed us to work with liver surgeons and thoracic surgeons to go and resect the metastatic disease, and something that would be considered non-curable or advanced, it is now curable if those metastases are resectable, meaning that they can be removed with surgery. So we talk to the liver surgeons, and we do combined operations where we remove a part of the colon and a part of the liver, and that patient is downstage and has a very reasonable cure rate.
Wow, incredible. Well, incredible advances you guys have made in colorectal cancer, detection, prevention, and obviously in treatment. And I know for me, the take-home message is colonoscopy, colonoscopy, colonoscopy. But if you wanted your viewers to, learn something today, what type of message would you convey as you're, we're signing off to our program and educating about colon cancer awareness?
In practice, what I've discovered, Tony, is that patients do not want to come and do a colonoscopy because they've heard it is terrible, right? That you have to drink 4 liters, 2 gallons of nasty liquid, right? And that gives horrible diarrhea, and that the colonoscopy hurts, et cetera, et cetera. But now what I want the viewers, your viewers, to know is that we've also made advances in that, right? Now, We do preps with very little liquid, sometimes even with tablets, and that helps clean the colon. So that part is a lot better tolerable now. The colonoscopy is done under sedation. The sedation techniques have also improved, and it's a very safe sedation. And the patients are sleeping totally unaware of what's going on. Also, the insufflation that we use nowadays is not with air. We use a different gas that helps decrease the pain associated with the colonoscopy. The majority of my patients are very happy. It takes me 30 minutes. They come in, they go out, they have breakfast after, and they are reassured that they don't have any tumors, and if they do, that they were removed before they were incurable. So that's what the message I want them to be. I want them to know is that colonoscopy is not bad and saves lives.
Yeah, I think that's very important. I can tell you, somebody who's had a few colonoscopies, I mean, the prep has gotten drastically better. You do have to clean the colon. So people have to understand you have to clean the colon. But the colonoscopy itself, I don't remember it. I just see the anesthesiologist. I go to sleep, and then when I wake up, that's it. And you're right. We go to have breakfast or go to lunch, and that's it. Well, Victor, thank you for coming.
Thank you very much, Tony.
Thank you for bringing awareness to our audience about colorectal cancer. And I think the take-home message is get your colonoscopy, bring awareness at age 45 or younger.
Right.
If you've had a first-degree relative with colon cancer, get your colonoscopies, be aware, and it's curable. So thank you once again.
Thank you, Tony.
And once again, Dr. Anthony Gonzalez with Miami Community Health, reminding you to be safe, take care of yourself and your family. Have a great day.